All right, everyone. We're going to go through quickly the first few slides in this treatment and evaluation unit. This is our last one. We sort of took our time in class, so this will actually probably be pretty quick. So just as I told people who were able to make it on Monday, this is, I think, of all the lectures that we, or all the slides that we go through in this class, I would make an argument that these are probably the most important, most relevant for those of you who have no interest in moving forward with psychology or psych classes, or have anything sort of future in terms of class work that you'll have to do in this field. If you learn something about psychology over the course of the semester, that's awesome. But here we're going to talk about for individuals who might be struggling with mental health difficulties or different types of issues that may help with some treatment, thinking about how do we go through, what do different treatments look like, and most importantly, how do we go through and test them and know that they're effective and something that's going to be helpful. So because I take a scientific approach to clinical work and clinical evaluation, I am a research and practice what we call evidence-based treatments. Okay. Now this starts to get a bit controversial. Sometimes there are certain areas of practice that sort of may have some benefits, but different techniques, different packages, different approaches don't always have the same level of evidence, right? And when we're talking about evidence, we're talking about scientific study where we've gone through and determined that yes, people who do participate in these treatments tend to get better, things along those lines. So, but this seems like it shouldn't be controversial, but it is sometimes. Sometimes people will argue that, well, what we're talking about here are sort of people's sort of being and sort of happiness and their approach to life, and that's not something that can be necessarily quantified or broken down into numbers, which is an argument, certainly, but if someone's going to come to me and receive treatment, I would want them to know that whatever we're going to do, whatever time and effort and energy that they put into this has been shown to be effective over the long run, and so sometimes there are types of treatments that are more effective, or that I guess based on the data that we have look like they're effective, and others that aren't, and that's just kind of the way the science works. So just letting you know this up front. Okay, so how do we go through and how do we evaluate these interventions? Okay, this is ends up being a pretty tricky situation. So what types of things, what types of outcomes might we use to go through and determine whether or not this intervention that I have is effective? Okay, I put it together. I wouldn't have put it together if I didn't think it was going to be effective. How do we go through and test to see that it's effective, right? Well, one thing that we could rely on in sort of gauging whether something would be effective would just be anecdotes. Okay, anecdotes are just stories. Anecdotes are, I had a friend who tried this and this was helpful for them, right? So obviously anecdotes can be helpful and help us sort of maybe direct attention to things that could be helpful, but not terribly helpful from a scientific standpoint in terms of evaluating whether or not something's useful. It's hard to know why something may have been beneficial for some person, or why someone might have liked some treatment. It's hard to know whether anybody else would have that same experience. And so while anecdotes, just saying, oh, well, maybe I'm talking with a fellow practitioner and they say, well, I've had sort of did this with someone and had some progress with that. It's information, but maybe not something we would want to rely on to be able to move forward and say scientifically establish that some treatment or some package was effective. Okay, we could also ask about client satisfaction, right? This seems like an important thing. If you or someone who you know comes in and works with me and we're going through and doing things, and I've got some study, and at the end of the day, we ask, how did you feel about that treatment? Did you like it? Did you think it was helpful? How satisfied are you with the services that you've received? Again, an important thing to take into consideration and something we definitely want to measure. But there's some things that make this in and of itself a difficult and flawed metric of whether or not something is actually useful for people. So one, and this is the big one, what we know is a lot of difficulties, mood difficulties, anxiety difficulties, some of the different disorders that we've talked about, they tend to wax and wane, okay? If you've gotten to a point where you're seeking treatment, probably things have gotten pretty bad. They may be the worst that they've ever been. But what we don't know is that it's possible, if you were to just continue on to treatment, whether or not things would sort of maybe get dropped down. Maybe you're not getting better 100%, but they're at least not as bad as they were when you come in if you were to just wait it out for, say, a couple of months, right? But what we don't know, unless we sort of put some safety checks in place, is if you come in and I'm giving you a treatment, I think it's going to work, and I tell you it's going to work, and you believe that sort of the story behind why this is going to work, and then all of a sudden at the end of 2 months you're feeling better than you were when you came in, you might say, oh yeah, no, this is seemed to be at least a little bit helpful. Well, what we don't know is whether or not you would have gotten better anyway if you would have just done nothing and came down as well, right? So what we call this is natural remission. Okay, and if you struggle with anxiety or depression or anything like that, you probably recognize this. Sometimes things get stressful, things get pretty bad, and then, after a while, it may take a while, things tend to get a little bit better, and then maybe they get a little bit worse. What we don't want to do, and what we can't tease out by just asking people, is it's hard for the client to tell whether or not that whether they got better because of the treatment or whether or not it was just something sort of that natural waxing and waning. Okay. We also see people motivated to justify their decision to seek treatment. If I'm going to go in and I'm going to spend time with in a study or with a therapist, and I'm paying $150 an hour, or I'm spending a bunch of time in sessions and working on assignments and doing all this stuff, some of that cognitive dissonance starts to come into play, right? If I'm putting time, money, and effort in there, and then nothing happens, that sort of makes me feel like, well, why did I go through and I put all that time, money, and effort into this? And so what we might see is that people become motivated to start to justify their why they sought treatments and put these resources in to begin with, right? So you might say, well, yeah, it was pretty good. I guess, I learned some things, and it was probably sort of better than not doing anything. So I guess it was okay, right? Because, yeah, otherwise I wouldn't have spent all this time, money, and effort stuck with this for, say, 2-3 months, right? But you did. And so what we can see is some of that cognitive dissonance and motivation to justify sort of why I persisted with this treatment in terms of satisfaction ratings. Same thing, some demand characteristics. If you come in, you work with me as part of a study, right? We probably, over the course of 2-3 months, if we're working on a 12-week treatment package, maybe longer depending on what we're working on, right? We develop a relationship, right? You know me, I know you, we have a good working relationship. So at the end of the day, you might not want to say, oh, Clap, your treatment was garbage or it wasn't very effective. We have some demand characteristics. You were getting active treatment, so you may feel pressure, implicit or explicit, to go through and say that things were sort of okay, even if they weren't super helpful. Okay, so again, client satisfaction for all of these reasons starts to become tricky as a primary measure of outcome. Okay, what we could also ask clinicians. We could say, hey, clinicians, you're all professionals, licensed professionals. How do you like this treatment? Is this treatment working all right? And the clinician could say, yeah, no, I feel like I have some success with this, or no, I don't think that it's so good. So again, some things that could provide information, but again, a lot of the same pitfalls as if we're asking clients. So we as clinicians are trained to do psychotherapy and all of that, but we're still human. We're still prone to the same biases that everybody else is. Getting your PhD or your master's in clinical counseling doesn't remove the potential for bias that you might not be aware of, right? And so once again, if I'm seeing you and you're getting better, I say, yeah, you're getting better. So I think this treatment is working. What I don't know is whether or not you would have gotten better or seen some reduction in symptoms similar to what we saw over the course of treatment if you had just not sort of gotten any treatment at all. Again, generally what we see is things don't get completely better. You don't get sort of back down to no symptoms. But if we see that you're doing better at the back end than you did at the front end, we can easily claim that as a treatment effect when in fact that was just going to happen anyway. Okay. As a clinician, I'm also going to be probably at some level motivated to justify my sort of power and skill as a clinician, right? And so if you ask me if treatment worked with you, I might be reticent to say, yeah, no, we didn't get anywhere. Boy, yeah, this was just too tough of a case and I didn't make any real progress on this, right? So probably, if anything, motivated to sort of give ourselves the benefit of the doubt and say, yeah, no, I think this treatment was pretty good. I think I made some progress with my client on this situation, again, something we want to watch out for. And then confirmation bias. Particularly if this is a treatment that I've developed, that I'm interested in, and I'm kind of motivated, I want to see it be effective, what I might do, again, following the same trap as any other human is vulnerable to, seeing the things that I want to see and ignoring or downplaying, not even explicitly, just maybe sort of accidentally, sort of not seeing or remembering all the places where this intervention failed. And so some confirmation bias is going to be the same, some difficulties there too. Okay. So our gold standard for evaluating whether or not a treatment is effective is going to be our randomized controlled trials, our RCTs. Okay. With our randomized controlled trial, what we do is we get a group of people. Let's say we've got a new treatment for depression. Okay. And what we do is we go through and we get a number of people who are looking for to receive treatment for depression, and we randomize them into 2 or 3 groups. Okay. And so we randomly assign people to get maybe, so let's say here we have maybe my experimental treatment. This is the one I'm actually interested in looking at. Treatment 2, here's maybe this is sort of just standard of care. This is what people are already doing to treat depression. And then maybe here, maybe this control, maybe this is a wait list. Maybe these are people who are in the study, they get randomized to a wait list and say, hey, you'll get treatment at the end of the study for right now. But right now we're just going to sort of check in with you every week to kind of see how you're doing, but you're not going to get any treatment right away. Okay. And so what we do is we randomize participants at the front to one of these conditions. Okay. Sometimes it might just be 2, doesn't have to be 3. It can just be maybe a treatment, sort of 2 different treatments or a treatment or control, something like that. And we go through and we measure, let's say, depression here at the front end. Okay. This randomization is very important. What it does, particularly if we have enough people, is it makes sure that any effects that we see on the backside can't be attributable to systematic differences here at the beginning, because you got randomly assigned to different conditions, and so there should be no, on the front end, differences that could sort of necessarily across conditions that could impact outcome. Okay, so we measure depression at the front end, go through. Everybody gets their treatment. Control people don't. They just kind of hang out and sort of are monitored, let's say on a weekly basis. But then let's say this is a 10-week treatment package. At 10 weeks, once treatment is done, we go through and measure where people are at post-treatment. Okay. And then maybe if we've got a good study, we have a follow-up, maybe 6 months, 12 months down the road. These follow-ups are expensive, but important to see, do whatever treatment gains we see over the course of intervention, do those persist, right? Because if I got a treatment and while you're in treatment and at the end of treatment, say 10 weeks, you're feeling much better, but as soon as we stop therapy, you're back to where you started, that's not a super good intervention. That's how medications work. Hopefully it's not how psychotherapy works, right? We want to see if you're getting better, that you're staying consistently better and seeing sort of maintenance of gains here, okay? And so what we do then is at post-treatment, we go through, and if treatment 1 is effective, what we want to say is see maybe that treatment 1 is at least as effective as stuff that's already going on out there, and hopefully much better than these people who just got monitored. This control condition, this is where we're going through and accounting for that natural remission. What we'll probably see is these individuals in control condition probably get a little bit better, maybe not a whole lot, maybe a couple points drops. What we want to see is that people in my experimental treatment group getting much better at post, or noticeably better at post treatment than people who were just allowed to sort of hang out without treatment and who just got monitoring, and maybe even better than maybe existing treatments and things like that. Okay, so this is our RCT. This is our gold standard. This is our best way of determining evidence for an intervention. Okay, but these interventions are not without their limitations. One, these are very, very time consuming and very, very expensive. It's not easy to get enough people rounded up all at the same time who are wanting treatment to go through and randomize to different conditions. There's a lot of staff that you need to have in order to make sure that people on the research team don't know necessarily who's assigned to what group to avoid bias. So there's lots of big sort of technicalities. So these tend to be very expensive, very time-consuming, kind of tedious studies to run. Okay. Also concerns about how do we select a placebo treatment. Okay. If I'm running say a medication study, right, then that's easy, right? I've got an active medication. I've got something that is, an inert substance, functionally like a sugar pill or something like that. And I say, okay, here, this group of people got randomized treatment, this randomized placebo, everybody gets pills. It's just the pills in for people in the cold control condition are just sort of some inert substance, right? Well, it's hard to think about how do we identify an inert substance in psychology, right? And then make that credible, right? I could have my placebo be, or my placebo treatment is standing on your head in the corner treatment. So I say, hey, Jane, come on in. No, this is a super awesome treatment. What we're going to do is we're going to have you stand your head in the corner for 50 minutes, and that's going to make blood rush to your head, and it's going to fix everything, right? That's not a credible treatment. That's not a real thing, right? People are going to obviously know that that's not a real thing, right? And so what we generally do is it's very hard to identify a true placebo. What we often do, we'll have people assigned to some sort of non-support or non-directive therapy, or just a supportive therapy. And so basically what this is you come in, we talk about whatever you want to talk about. I don't have an agenda. I don't provide you with advice. I just kind of listen and am empathic. A lot of that Rogerian stuff that we've talked about, sort of the humanistic types of things, right? And I just am there. I'm a person to talk to. But even that, right? We might not be actively treating your symptoms of OCD or panic or depression or PTSD, but what we are doing is we're providing you an opportunity to interact with somebody, to talk and express in a non-judgmental venue, and that's probably going to be helpful, right? It might not have active components to it, but overall it's still going to be helpful. So it's not a placebo in that it's inert, right? And so figuring out what our comparison groups are going to be and trying to identify some placebo intervention or condition starts to become hard with these types of studies. Okay, and then the last limitation is questions about whether or not these types of studies generalize to real-world settings. So again, I said these were very time-consuming, very staff-intensive, right? There are multiple clinicians, people coordinating stuff. You've generally got people making sure that clients are showing up on time and doing any assignments that are associated with the treatment in order to get maybe a clean sample. You're saying, okay, well, anybody who has comorbid substance use or alcohol use, they can't be in the treatment. And then if you can't get to, you have to be able to get to the university and be able to attend regularly. Otherwise, you can't be in. And you have to have your own, say, child care. Otherwise, you can't come in. You can't have currently be on any other medications for any other thing. Otherwise, you can't participate in the study. And maybe you need to be able to devote, X hours a day to practice and things like that, right? And so, which is fine. You can run that study. Maybe you find something that works. But then if I'm Joe Clinician out in the universe, I say, well, But that's not the people I see. The people I see, the real people coming in to see me, have depression, and they also maybe drink too much, or they might be using substances. They may have a lot of other disorders, and maybe they don't have reliable transportation because they're depressed and they don't have a job, and they can't sort of reliably get to sessions. So we have to be flexible. I work with people who have children, and maybe they don't have time, or between kids and work, they don't have time to spend X amount of hours each day sort of working on things, right? And so for the purposes of scientific study, we can start to make our inclusion criteria so specific that it starts to not look like anybody who actually has this condition out in the real world. And then there's questions about the external validity of our results. So fine, with this very limited slice of people with this condition, and if I have all the resources of a university, yeah, I can see gains in individuals. But is that useful for me to know if I'm in a private practice out sort of in the world, right? So these are the very real limitations of this design, and we sort of then have other things that we're trying to do to address some of these things. But again, our gold standard is not without some limitations. All right. So when we're talking about, so we've talked about up to this point, introduced the idea of empirically supported interventions. These are going to be interventions that we have evidence from research suggesting that yes, these approaches, these packages have merit, and we do see systematic improvements in people who are going through and completing these different interventions. But like anything else we've talked about, it's not a black or white thing, right? It's not like, oh, I don't have evidence, or I have no evidence at all, or 100% certain that this absolutely is effective, right? And so what we do is we have some different levels, okay? If I'm talking about a level 1 treatment, we talk about these as well-established treatments. These are interventions that have at least 2 well-designed between group studies that show that my treatment that I'm looking at is superior to some placebo. In this case, it's generally that's going to be like sort of non-directive, person-centered therapy types of things, just kind of reflective supportive therapy, so that my study is superior to sort of that or some other treatment, or alternatively, that my treatment is, people in my treatment are getting as good as, are getting the same level of gains as participants who are randomized to an already existing well-established treatment. So if there's a well-established treatment for depression out there, and I come up with something new, and we put those, the existing well-established treatment, my treatment head-to-head, and people get better at about the same level, then we would see evidence of equivalence here. Otherwise, what we're looking at is superiority to some other treatment or just some sort of supportive condition. So if we have 2 studies that are well designed that are demonstrating this, we would identify this as a well-established treatment. Okay, level 2. These are going to be probably efficacious treatments. These are going to be interventions that don't quite hit the same threshold of evidence, but they're looking like they're going to be pretty good. And what we have here is we need 2 studies showing that my treatment that I'm looking at is superior to some weightless control. Okay. What we want to see here is that if I randomize people to my treatment and randomize the other, everybody else gets randomized to some monitoring condition where every week we go through and measure maybe their symptoms, but they're not getting active treatment. They're just kind of hanging out. They'll get treatment after the study's done. What we want to see is at least 2 studies showing that my treatment is outperforming people who are just sort of waiting in to get treatment, not actually receiving intervention. Okay, what this does with the probably efficacious treatments is that we're able to say with these that my intervention is doing better. The gains that I'm seeing in my intervention, or at least I know, not attributable to just a natural remission or regression to the mean or things along these lines. Okay, so again, 2 studies showing that my intervention outperforms or does better than someone who, or the group that's just sort of monitoring symptoms, that's going to be our level 2 probably efficacious treatment. And last, we got level 3. These are going to be promising interventions. Here we have evidence of positive effects, but we don't have enough research to say that they're probably efficacious. What we generally see in terms of level 3 evidence is, let's say that I've developed a new treatment for eating disorders, okay? But it's kind of new. I've got a new approach, and what we see is positive effects in what we would call uncontrolled trials. So what I'm doing is I'm recruiting people to come through. Everybody in my study, and they're usually small. Maybe I got 15 people in my study, and all 15 people, they all get my treatment, so there's no control conditions. I'm just bringing people in. They're getting the intervention, and we're seeing positive effects from start to finish on people who are receiving this treatment, right? So again, what we would call this a promising intervention. Looks like, yeah, people who are coming in for this are better when they leave than when they started. But what we don't know is whether or not those are due to other factors, or whether or not that's just sort of regression to the mean, or natural remission, or things along those lines. So looks like we have some evidence, but not something that we would that would rise to the level of probably efficacious or well-established treatment. So these are just some systems that have been put in place to try and categorize strength of evidence for different types of treatment approaches. Okay. So this is where we finished up in terms of lecture on Monday, talking about psychodynamic therapy. Now we've gone through and talked about psychodynamic figures and psychodynamic movement, sort of aspects of this at previous points in the semester. We're talking about psychodynamic therapy. Freud, kind of the father of this, but there are other figures who are influential in terms of their writing and approach. Carl Jung, Alfred Adler, Erik Erikson. These are influential figures within psychodynamic in the psychodynamic movement. The goals of psychodynamic therapy are to talk about these as insight-related therapies. And what we want to do with these types of interventions is practitioners are trying to identify what they would identify as unconscious conflicts that contribute to distress. So again, remember that from a psychodynamic theory, this idea of the unconscious being things that you can't pull up, know about, or identify, but what we do is through free association, projective tests, sort of evaluation of transference, countertransference, things along these lines, what we start to do is start to make guesses as to what may be going on in terms of issues or conflicts going on in your unconscious that are sort of bubbling to the surface and impacting sort of your day-to-day functioning. A lot of times this is looking at what practitioners in this area would identify as unresolved childhood experiences, right? So what types of things, disappointments, needs did you not have as a child that is now impacting your pattern of behavior? So let's say your family life early on was very rigid and structured, and you didn't maybe get a lot of love and attention from, let's say, your mother, okay? And so, but now you are seeking out, have a hard time, maybe you're super rigid, having a hard time interpersonally with sort of being flexible with other people. If people sort of don't always do what they say, then it throws you off base, and sort of other people say, hey, you need to calm down, you're too rigid about things, and you tend to find yourself attracted to people who are kind of cold and unavailable. I don't know. I don't do this type of therapy, but this is kind of idea, like sort of these things in childhood are sort of impacting sort of now behaviors that we're seeing today that are causing you some problems. And then what we're doing here is addressing and recognizing defense mechanisms, your efforts to avoid or sort of work with and express yourself in ways that are less threatening to you. So we would say, if I'm super competitive, right, and I go around and say, oh, Jim's so competitive and everybody's so competitive and no one likes him because he's so abrasive and he always is so focused on winning, right? And maybe my friends are like, I don't know what you're talking. You're the one who's always focused on winning, right? I don't like. It's this projection, right? Taking the things about myself that I don't like and projecting them on other people, right? So identifying these different defense mechanisms that come up in psychodynamic theory and sort of recognizing that this is how I go about my life. Primary techniques. Some free association. So again, maybe I'm just kind of talking about whatever's on my mind, and then the clinician trying to use that to identify, stuff that's going on, conflicts in my subconscious, looking at resistance. For many people who practice this, there are no such thing as accidents. So let's say that you show up to my office 20 minutes late. Right, and we were supposed to meet at 3. You show up at 3:20, and you're back. Oh boy, my car broke down, and then I couldn't sort of make it. Right. Well, to most of us, we would say, yeah, it sounds like you just had a rotten day. But if I'm a dynamic therapist, I might sort of start asking about sort of what types of things would maybe sort of led you to this to happen. Right. The idea being that in situations like this, if I've asked you to do something or you're not showing up for treatment, so that in some way is a manifestation of you of trying to intentionally thwart subconsciously your ability to move forward and address some of these things and work through stuff. Okay, so again, from a psychodynamics standpoint, we would say there are no accidents. Things happen because subconsciously, like, you've sort of set things up to sort of for this to go on, right? And so I say, what does that mean? What does that mean about sort of our work? Things along those lines, okay? And then finally, looking at what in psychodynamic therapy is known as transference and countertransference within the context of our time in session, right? So transference is going to be your impressions of me that from a dynamic standpoint aren't about me. They're about your own conflicts and your own unresolved childhood issues. And so maybe you really don't like me, which could be the case, right? And you think that I'm a know-it-all and that I just don't know what I'm talking about, and that I think that I'm better than you, and that really makes you angry, right? Well, maybe I might say, well, I don't think I know everything. I don't think I'm better than you. Maybe what you're feeling towards me isn't sort of about me. Maybe it's about your feelings about sort of important people in your past, and you've had that, and so I just represent that to you now, and so now you're reacting. You're transferring that to me when it's not about me. It's about sort of people who have hurt you in your past, and I'm sort of the stand-in for that person, even though I haven't contributed to that, right? So that would be kind of a transference issue. Countertransference is this idea of you coming in and you're doing your thing and me eliciting feelings from me. And so maybe you're coming in and I was like, boy, I've got this client who's pretty abrasive and they're kind of hard to be around. And so maybe sort of me evaluating what about my own past is sort of influencing what about you is triggering things in my own past that are making me react to you in a certain way, and how does maybe that cause sort of our other people in your life feeling similar way that I feel to you. And so again, just it's sort of a deep dive into the evaluation of this therapeutic relationship and sort of how this dynamic all plays out. Okay. So level 1 treatments from a psychodynamic therapy. Now, I will say I didn't study in this modality. I'm not a dynamic person. Well, I'm a very dynamic person in terms of just being personally engaging. But from a psychodynamic standpoint, not that type of dynamic standpoint. If not many people do old school Freudian therapy, right? Like the straight up psychoanalysis type of thing where you come in, lay on a couch, I'm behind you, just talk, and so I write things down and stuff like that. There are sort of more modern sort of approaches that still rely heavily on this dynamic type of approach. And we have found that these dynamic therapies, they tend to be sort of long, oftentimes so multiple little sessions a week coming in and quite lengthy, but finding that we do have evidence for psychodynamic therapies as being effective for major depression, and so identifying this as a level 1 treatment for major depressive disorder. Okay. All right, that's it. That's everything we went through in lecture on Monday. What we'll do is this coming Monday, we'll finish up with the last of these slides and then have quiz 7 on Wednesday. Okay. Remember that quiz 7 is mandatory. Have to take that. So make sure that you study, make sure that you're reading modules, get all this put together so that you're ready to go for this last quiz. All right. Thanks, everybody. Let me know if you have any questions. Otherwise, I'll see you all on Monday. All right.